So today we're going to be talking about leptomeningeal versus pachymeningeal in neuro-ophthalmology, both radiographically and clinically. So they're both meningeal, and we can see meningeal disease on the MRI scan with contrast, the gadolinium. That's going to show enhancement. So it's going to be bright on the T1 post contrast. And the difference is, even though they're both meninges, the meninges actually has three pieces. It has a dura mater, the arachnoid, and the pia. Both leptomeningeal and pachymeningeal involve the arachnoid, but pachymeningeal is a dural enhancement, and leptomeningeal is a pial enhancement. So one is arachnopial, and one is dura-arachnoid, which is pachy. And these two words, they mean something. So pachy means thick, like pachyderm, which is elephant. So the elephant has very thick skin. He's a pachyderm, thick-skinned pachyderm, like dermis. And lepto is thin. So we got a thin version of the enhancement and a thick version of the enhancement. And so when we see this on the MRI scan, pachymeningitis is like a rind of a fruit, like an orange. It goes all the way around, or it can be focal. This is pachymeningitis, the thick version of it. And the leptomeningeal enhancement is like a thin version of it. So it's in the meninges, it's in the arachnoid, but it goes down into the sulci. It's a thin version of it. So I got a thick version of it, like a rind, and I got a thin version of it, which is lepto. When you have pachymeningeal enhancement, that most common cause of that is low intracranial pressure, intracranial hypotension, because it's caused by venous stasis and venous engorgement, and it's diffuse. If you got pachymeningeal, but it's nodular like that, you can't blame that on the intracranial pressure, because the intracranial pressure is diffusely felt all through the head. So if it's nodular or focal or just one place, you really shouldn't pick ICP. That's likely to be something in those meninges. And the things that go in there are cancer, dural metastasis, or meningeal disease from inflammation like sarcoidosis, granulomatous disease, or infectious processes, tuberculosis. So that's why pachymeningeal has a different differential diagnosis than leptomeningeal, which is much more likely to be meningitis or meningoencephalitis. So leptomeningeal, meningitis, pachymeningeal, inflammation, infection, something's in there, usually granulomatous or neoplastic. However, both leptomeningeal and pachymeningeal can be neoplastic. It tells you something's wrong, it doesn't tell you what it is. So if you see the nodular or focal versions of these, you really have to worry that it might be neoplastic. And so we're going to do a lumbar puncture in these patients. We're going to look for CSF pleocytosis. We're going to test for the usual infectious and inflammatory agents. We're going to do a CT of the body to look for a neoplasm, and you're going to do cytology and flow cytometry with high volume on this CSF to avoid having to do a biopsy. If there's no other place for a biopsy, CAT scan, PET scan, LP, no history of cancer, you still might have to do a leptomeningeal or pachymeningeal biopsy. That's neurosurgery. We saved that for last. So you need to know the difference between the thin version and the thick version of meningeal enhancement on the MR. They need to have a workup. Look for infectious, inflammatory, infiltrative, and neoplastic etiologies, spinal tap, high volume cytology, and if you still need the answer, go get a biopsy.